Hi, I'm John Kwan. I'm a periodontist here in the Oakland-Berkeley area and the clinical director for Perioscopy, which is a Danville materials company. Today, what we're going to be going through is typical training. We're going to be talking about how to set up the unit, and then also we'll be doing some bench training. Then we'll be going into some clinical treatment so that you can see how this is done. Not only how I do it or how experienced people do it, but how we train new hygienists and dentists to do this technique. The unit comes pretty much all assembled, but it does require some assembly. And that assembly instructions are in the operator's manual. This operator's manual comes with a hard copy, and then there's also a digital copy. It's really important to read the manual. When we start out, we're going to be starting out going over the checklist. The system comes with a Perioscopy system setup checklist. And the good thing about this is that if doctors are using it, typically an assistant is going to be using this checklist. Most of the time hygienists will be doing this setup themselves. So the first thing on the checklist is to plug in the unit, and we have the unit plugged in. You fill the water bottle and you attach it to this regulator, and this is what we call the regulator. And this is a water bottle that's not unlike the water bottles that are found in most dental offices. So you attach the water bottle, and there's an on and off switch here that you flip. You can hear the air pressure going, and you turn it on. This is a water bottle, but it's driven by air pressure, and it requires an air quick connect. And these air quick connects are very standard for air and water. Most offices have the same quick connect for air and for water. So it's important that you do not hook the air quick connect to a water line. Some offices have a large bore air quick connect so that they can be distinguished between the air and the water. And so you don't make a mistake, because you can't plug in this say if it's a water quick connect into the air line. But if your operatories are like that, you will need to have an adapter, because the Perioscopy system comes with a smaller quick connect. So we've attached the water bottle, we flip the switch to on, and then you need to check the air pressure. And the air pressure is indicated on this air pressure dial. It should be set at 60. One of the things I want to show you too is that there's an air pressure regulator knob. And if you need to change the air pressure, you can change it with this knob here. This knob does have a lock washer. And sometimes that lock washer, well, if it's locked, it prevents you from being able to adjust this. So a lot of times the unit will come and this will be locked. You need to take some pliers and unlock it, adjust it, and then I would just hand tighten that lock nut. Okay, next on the checklist is check the water flow before attaching the sheath. So there is an air activated pedal for the water. Got the water hooked up. Okay, so that's plenty of water coming through. Attach the Perioscopy fiber. We have, in our office, we keep the fiber attached. But just to show you what that looks like, the fibers come in a box, and some offices will want to take the fiber on and off, but I don't recommend doing that, because it's another thing that you have to do each time. And although when we're using these fibers, normally what we do is we put the date on the fiber so we get an idea of how long these last. You can also count the uses of the fiber if you, and maybe you can have a little checklist or something that shows, some offices do that. They document each use of the fiber so they know how many uses. We expect you to get at least 50 uses out of this fiber, but sometimes they'll wear, or if you pull on them, sometimes they'll break. Turn on the controller. So we're going to turn on the controller. It has an on and off switch. This is a kind of an international symbol. The on is a little line and the off is like an O for off. And then we're also going to turn on the monitor. This particular monitor has a button because it's an older monitor. The monitors that come now have a touch screen, and all of the settings are set in there, so you shouldn't have to make any adjustments to the settings. Next on the checklist, turn on the controller and the monitor, and as needed, check the focus. And we like to check the focus with the orange protective sleeve on because it allows you to see the edge of the image. And this unit, this is where the camera is located, this is where the light source is located, and actually this handle is a medical endoscope that a physician would use and clip various probes to this to work on things like knees and shoulders. But it does have a focus knob. So the focus knob can be turned so that you have a nice sharp outline. And normally, if you set that focus, you don't have to reset the focus. Next on the checklist is carefully remove the orange protective sleeve. This has a lure connection that just unscrews. And generally what we do is we just put this to the side, or sometimes our assistants will just loop it around and just let it hang. For now, I'm just going to loop this and put it to the side. This particular fiber is 1 meter long and 1 millimeter in diameter. Inside this 1 millimeter diameter are 19 light guides. Inside those light guides are very small, and you can barely see the outlines of them, very small 2-micron mirror tubes. So you can look at things like, these are my fingertips. This is my shirt. You can also look at some text to see if you're in focus. So, on the controller box, it has a window setting, a gain control setting, and a white balance setting. This is also an illumination setting, so as this fiber gets older, you may need to increase the illumination. Although one of the things that happens with this illumination knob is that if the illumination is too high, the camera in here will adjust it anyway. Okay, so we're going to, first thing it says is confirm the window is set at 6. So I'm going to press the window button, and you can see it says window 6. But for example, say you press it another time, it may go to integral. Then you keep pressing, and this window becomes smaller and smaller until you get to 6. There's also a gain control setting, which is a brightness and contrast setting, and those are explained in the operator's manual, and then there's also a separate instructions for use for the controller that comes with this system. So I'm going to look at the gain control. The gain control has 3 different settings. It should be set at 00 dB, but you need to confirm that each time you use this. So because it could be on 10 dB, or it could be on 12 dB, but you want it on 00 dB for the best image for perioscopy. Then also, the last thing we do is set the white balance. And what you do is you take the end of the fiber and you put it on this green chip, or you can put it on the frame of the monitor, either one. But this particular color gives you the correct color set. So I press the button. When I release the button, it says OK, and then I'm OK. Say, for example, if I set the white balance on my black shirt, the coloration is totally different. Then if I set it on this green chip, the coloration is more lifelike. That's my fingertip or fingerprint. This fiber does not need to be cleaned because we're putting a sterile sheet over the fiber. However, if you end up cleaning this with certain products, it can end up affecting the clarity of the lens at the end. And that becomes an issue sometimes, and it's not real easy to get that to come off. So if you're going to clean this at all, just use alcohol. Okay, so we've checked our image without the perioscopy sheath. Then you carefully attach the perioscopy sheath. These sheets come in boxes of 5, and that's the minimum purchase of these. Then based upon the price point, the more boxes you buy, the lower the cost. The sheaths are single-use sterile sheets, and they also have a label with a lot number. It's important that you keep this throughout the procedure, because if you have a problem with the sheath, you're going to want to send it back to Danville Materials for credit on your next purchase of sheaths. And then you can also document the problem and look to see if there are trends in some of these problems, but they rarely have problems with these. Probably the most common problem is that as you're putting the fiber into the sheath, it may get stuck near the end, and you don't want to really push it or force it. However, that doesn't happen very often. For purposes of demonstration, for this bench training, I have a demo sheet. We're not going to be hooking up the water to this, but actually I'll hook it up because that's part of the checklist. So what you do is you take the fiber, you put it in the fiber tube, which is the clear tube, and you just gently push that until it goes to the end, and then you hook it to the lure connection. Then you can also hook the water to the lure connection. Attach the sheet to the water tube, and then check the water. The water should be streaming out like that. Okay, so then you attach what we call the sheath fiber complex to the first Explorer. Let me go over this the sheath a little bit. The sheath has 2 tubes, a fiber tube and a water tube. It also has this small plastic end we call a tip seal, and then the metal end we call a window cell, or you can call it a metal cannula. The metal cannula has a bonded sapphire lens at the end, and that totally isolates the fiber from the oral environment. Perioscopy system requires using what we call explorers. There are 4 different explorers. This is a left explorer. It's indicated by a yellow band. The left explorer looks to the left. The right explorer looks to the right. These bent explorers are bent so they can look forward in the mouth. these right and left explorers can look to the sides of teeth and then look backwards in the mouth. And in the anterior, they could look to either side, the facial and, say, for in this case, the distal. The explorer has several parts. It has a handle, it has a channel, it has a cone socket, and it has a shield. So we're going to start using the left explorer and just talk about how you put the sheath fiber complex into the explorer. And this is also explained in the operator's manual with multiple pictures. So you hold the sheath fiber complex by the tip seal with the water tube toward the inside of your hand. You place the metal cannula or the window cell straight in, you twist it, and we're trying to twist this so that it seals the tip seal into the cone socket, and then also so that these two tubes are as parallel as possible going in to the channel. And the reason we want to have the fiber tube go in first is because when we take this out, it's much easier to take out with the water tube coming out first because it's smaller. This is how you're going to hold the explorer when you're using it. So this is how we recommend holding the explorer while you're taking the sheath fiber complex in and out of the explorer, because you will be changing explorers going around the mouth. So again, place it in, straight in, twist it, not with your glove in there. With your hand in the same place, you just snap it in the channel and you're ready to go. When you take it out, you take it out the same way. Place it in, snap it in, snap it out, pull it straight out gently. Okay, so we've got this ready to go. Now what we're going to do is we're going to be looking at the screen and having the screen guide our movements as we play this video game. If you look at the screen here, what you see is the end of the shield. Okay, those are my gloves. So when we play this game, you look down at number 1, and we're going to do it with the right hand first. So look down with number 1, and then we're going to trace this line, looking at the screen to govern your movements. But what this does is this helps you direct your movements looking at the screen. Then we do this with the right hand, or the left hand, or your non-dominant hand. Okay, because this is like when you use a dental mirror, you use your non-dominant hand. And when we use a perioscope, we use our non-dominant hand because we have an ultrasonic in the other hand. So now I'm going to take this out, and our trainee Katrina is going to be doing this next. So you want to hold on to the tip seal with the water tube toward the inside of your hand. Bring it up straight. So you're just going to place it in like that. Twist it the other way. There you go. And then just flip it into the channel from here. Don't move your left hand. Good. Okay, now put it in your right hand and just trace the lines. Again, this gets you used to using the screen to govern your movements. Because this is an endoscopic procedure, so it's all going by the screen. Now in the mouth, you are using some tactile sense as well. As you get better at this and you're moving along, you feel, you position in the mouth, you feel your way around, but you're looking as well. Okay, good. So do it with your left hand. Good. Now take it out. And clip it right from where you put it in. Yeah. And pull it straight out. Okay, see how she's holding it just like she's going to be using it. Some people will end up doing this, and if you're left-handed though, what we recommend is you put it in like you're a right-handed person, because this channel is not really conducive to a left-handed world. And the reason we're going to be taking the Explorer in and out each time is because this trains you to do it the same way every time. Okay, so now I'm going to put this in the same way. And we're going to look at the model. This Explorer will look to the distal lingual of the upper left, along the lingual, and then into the interproximal as you turn it sideways. As you can note, you can see that there's a shield, and looking at the screen, you can see that there's an angle here and there's an angle here. And what we want to do is try to keep those angles equal, because the more equal they are, the more you're going to see of the tooth. Because normally there might be soft tissue here, and the more soft tissue here is here, you're only going to see a small amount, whereas if you have equal amounts of soft tissue on either side, then you're going to see a larger amount of the tooth surface. So these we call an open and closed angle. We also have closed and open angles moving axially on the tooth. And then when we're interproximally, we also have closed and open angles. So there's a lot of times during the training where we'll be talking about close that angle, open that angle, and it's at various directions based upon how you have the Explorer positioned subgingivally. So what we're going to do now is this model kind of sticks down. And when we're working, we're normally working at 11 o'clock because that's the most efficient position for a right-handed person to operate in the mouth. So look in the mouth, position it at the distal lingual, and look at the screen and move around. When you get to the interproximal, we have to go sideways and go in. Then I'm going to look in the mouth. I'm going to position it at the distal lingual of the first molar, look at the screen, try to keep my angles equal, and then we're going interproximally. And then we're going to do that all the way up to the cuspid. Then we'll be taking this out and putting it back in. If I'm using the right Explorer, for example, the right Explorer will look at the buccal aspect and into the mesial, or the lingual aspect of the upper right and into the mesial. On the lower, we don't use the red Explorer that much, And the reason why is because it's not real easy to turn your hand like this to go to the lingual or to the buccal. So in the lower, and we'll get to this a little more, actually let me show how we use these bent explorers. These bent explorers will look forward in the mouth, so you can look at the distal aspect of the upper molar, upper left molars from the lingual, or the upper right molars from the buccal. So this array of explorers allows you to look and clean around each tooth. On the lower, however, because I can use the left explorer for the buccal and the mesial, the left explorer I can use for the distal and the lingual. We normally use 2 explorers on the lower and 4 explorers on the upper, especially in the upper molars, because the upper molars are much wider, and you need to approach them from both sides. Okay, so I'm going to take this out, and then I'm going to have Katrina put the left explorer on and just go around looking at, go around the tooth and look at the screen. So hold on to the tip seal. The water tube toward the inside. That straight in, twist it, flip it into the channel, right from in here. Good. Now that's not going to move. So just look in the mouth, position at the distal lingual of the second molar. The second molar. Good. Now look at the screen and start moving around. Good. Now twist it sideways and go in approximately. Good. Now go to the first molar. Twist it sideways. We're typically taught to use instruments parallel, or as parallel as possible, to the long axis of the tooth. And that's what we do when we're endoscopically cleaning on the buccal and the lingual, but in the interproximal, you end up having to go perpendicular to the long axis to get interproximally. And then certainly, the deeper the pocket, the more you're going to be going parallel to the long axis of the tooth. So look in the mouth, position the instruments, look at the screen, move around. Go ahead and take that out. Okay, the next thing we're going to do, and you'll note again, we're just going to be taking this in and out, so you get practice doing it the same way every time. The next thing we're going to do is we're going to take our model and we're going to position the endoscope or the perioscope right at the midlingual of the first molar. I'm looking at these different angles. Then I'm going to pick up the ultrasonic and I'm going to put it in what we call the visual field. I'm going to move around in the visual field looking at the screen. I want to try to keep the end of the ultrasonic in the visual field. I don't want to go out like that. I want to try to keep it in the visual field. Like for example, there's a little white spot right there. That could be a little bit of calculus. And you make incredibly small movements. This is maybe a total of 3 millimeters. And so we're able to see calculus that's maybe 1/10 of a millimeter. Calculus will tend to look white or yellow under this kind of illumination subjectively. Okay, so we're just going to go around and try to stay in the visual field, looking at the screen. Okay, good. Keep moving around in the visual field. Now try opening this angle a little more. Good. Just looking at the screen. Open that angle a little more. Keep opening it. Good. Now close that angle. Open this one. Good. Now see if you're going to open and close the angle toward the tooth. There you go. Good. That's open. That's closed. Alright, keep the ultrasonic in there. When we're scoping, sometimes the ultrasonic is coming from the distal aspect, the mesial aspect, or just straight up. Okay, try to keep that in the visual field. Now make a little tiny circle right around the end of the pen. Little tiny circle. Smaller. And see how small these movements can be. Okay, make it over here. So what she's doing is she's looking at the screen, and the screen is governing her movements. She's looking to where she wants to go by looking at the screen. Okay, right there, that little white spot. Good. Over here. Great. What I'll do now is explain what instruments we use. We typically use an instrument that's magnetostrictive. Ultrasonics are either magnetostrictive or piezo. And it doesn't really matter what you use, as long as you use something that looks like a perioprobe, a very simple instrument. About 99% or more of the time, we use just one instrument. However, there may be times when we can't open up this angle enough to get this tip to move forward into, say, a furcation. Or on the lower, say we can't open this up enough to get underneath the CEJ here, because the mouth just doesn't open like that. Well, in order to gain that angle, we may use a curved ultrasonic. So it's important to have a straight one and two curved ones. So for example, if I want to get here and I can't open up this angle enough, I can just do it with a curved instrument. It's much easier. Same thing here. If I can't open up this angle enough, I can get in there with a curved instrument. Now all ultrasonics have a tremendous amount of power at the very tip compared to the sides. But you can utilize that power, especially if you're seeing what you're doing. And for example, here it makes it much easier just to use the tip lightly, to use that power to remove calculus when you're using these curved ultrasonic. Typically we're using just 3 instruments, straight and 2 curved. Once in a while we use these. The advanced set is the same instruments and they're diamond coated. Now this is a far departure from the typical periotherapy hand instrument setup. Periotherapy hand instrument setups have maybe an array of anywhere from 8 to 10 plus instruments, and they're all different angles to make up for the fact that you can't see. But when you can see, all you need basically is just one instrument and then maybe a couple extra. The initial part of the training requires that you watch a number of short videos on the Perioscopy website. That goes over the technology, it goes over how you put the sheath on, it goes over the explorers, and there are also videos on explorer positioning. And that's real important to watch the explorer positioning videos. And then we also have explorer positioning diagrams. These can be printed out in all four on one page. They can be printed out one on a page. When you look at these, this is the upper and this is the lower. And that's the reason is because when I look at patients, I look at them this way. However, if it's better for you to look at them this way, that's fine. Whatever works. I have one hygienist during her training, she took all of these colors and put them on one. So whatever works for your brain. Also, this is a two-handed, two-footed procedure. And so you're going to be running the water on the endoscope with one foot and turning the ultrasonic on and off with another foot. Now, some people would rather do contralateral foot. Like me, for example, I use my right foot to run the water for the camera, which is in my left hand. And I use my left foot for the ultrasonic, which is in my right hand. But whatever you're comfortable with, whatever your brain is comfortable with, is how you want to do it. So now what we're going to do is we're going to go into the patient treatment portion of the training. So when we set this up, we generally put a barrier on the handle in case I need to move this back or forth. We also put a barrier on the fiber clip so that if I need to move this fiber, we can move it and then you're just touching the barrier. For a right-handed operator, we take the fiber and bring it out on the left side of the monitor looking at it. It's just the opposite on the other side if you're left-handed operator. My assistant has already set up the first explorer because I normally start on the upper left and I start on the lingual of the upper left. We've done the anesthesia already, and on the upper we typically use articaine and just infiltrate all the way around. In this case, we've just done the upper, the posterior of the upper left and the upper right. On the lower, since she's got some localized pocketing, we've also done infiltration on the buccal, and then we'll probably end up infiltrating through the papilla, because generally with articaine, on the upper it will penetrate all the way to the palatal, but on the lower it typically doesn't go all the way to the lingual. We also use, obviously you have to have a saliva ejector because there's water coming from both instruments, the ultrasonic and the endoscope. And what we use on the ends of these are soft stops. It's a product that's made by Smart Practice. There are other brands of these kind of things, but what we found is the soft stop works the best. You just put this on over the saliva ejector. It's also what I call a suction muffler because it kind of more evens the sound of the saliva ejector, which can be annoying. So when I bend this, and then the saliva ejector should extend a couple millimeters from the end of the saliva ejector. When I bend this, I bend it around my finger so that these two are parallel. The two tubes are parallel. Then I'll bend it a little bit this way and a little bit this way on one end so it looks like a snowshoe. When you're doing perioscopy, you should have the saliva ejector on the side that you're working on. And the reason why is because you don't want water constantly going over the tongue. The patient starts swallowing, and they keep swallowing, and by the third to the fifth swallow, they're going to cough. Okay, turn to the left, open real wide. Okay, I'm going to put the saliva ejector in there. And see how it just, you want it to passively rest just distal to the molar. Then we're going to use a bite block or a mouth prop. These are just styrofoam disposable ones. You can use different ones if you'd like. Some people actually use an isolite or that kind of bite light type thing. Okay, open, and go ahead and close on that. You okay like that? Okay. So I got my ultrasonic. We use manually tuned ultrasonic. Again, I have my left foot running the ultrasonic. When we use these ultrasonics, when you hold the handle, here I'll turn this off for the moment. When you hold this handle, the cord tends to pull on you because the point of rotation is over here. If you bring the cord, what I call back around the back, the point of rotation goes here. It's much more ergonomic. With magnetostrictive ultrasonics, you do have an insert, and the insert can rotate. So what you want to do is you want to rotate it so that you don't have to turn it so much. If you have to turn it so much, then rotate the instrument. Okay, I'm going to lean you back a little bit more. Turn the saliva ejector on. Turn to the left. Normally what I do is tune the ultrasonic. Well, this is manually tuned. So what I want is I want the water to be swelling, and you can see that it is. When I turn the tuning knob and it's not swelling, it doesn't have as much power. So I want it swelling. I don't need to tune it so it's spraying. Okay, so what I do first generally is I do a tactile debridement. I go around with the ultrasonic. I'm removing plaque. In a heavy case with calculus, I'm removing calculus. You can see I'm using a mirror and there's no water spraying on the mirror. So that's why we like manual tuning. Automatic tuning, generally you have more water spray. A lot of times with piezo, the power is up way too high. So what I recommend is you just take the power on the piezo and turn it all the way down. You notice I turn the ultrasonic because I'm moving toward the other side. It's starting to spray a little bit, so I'm going to tune it down a little bit. Okay, turn to this side. Okay, so I've done my tactile debridement. I'm going to pick up my first explorer, which is the left explorer. Turn to the left. So, since I don't have a mirror, sometimes I'll use the explorer and the ultrasonic to retract, like to move the cheek out of the way, for example, like this. So you don't need the mirror. You can hold the mirror and just bring it to the side and hold the explorer as well, but that's a little complicated at the beginning, so some people do that. And you want to position these pedals so that they're comfortable. Okay, I'm going to look in the back of the mouth. I'm going to position this right at the distal lingual aspect of the second molar. I'm going to put my ultrasonic in there, and then I'm going to look at the screen. I'm going to turn the water on, turn the ultrasonic on. If I open the angle, I can't see anything because the water's rushing over the camera and it's not on the tooth. If I close the angle, I can now see the tooth. So I'll point out what we're looking at here. This is the shield, there's soft tissue, this is the distal lingual line angle, and I'm cleaning around the distal lingual line angle. I can go a little bit into the distal, but in this tooth it's really broad, so to see the distal, I'm going to need to use the angled explorer. Are you doing okay?
Uh-huh.
Okay, now I'm moving the explorer toward the palatal aspect.
and I need to close that angle more. Okay, this water is not coming out. Oh, there we go. So I need to close the angle so I can see the tooth. And that's not unusual for shallow pockets. Okay, now I'm going into the mesial. You can see there's some plaque there. There's a crown margin right there. There's soft tissue. I'm going to go a little further into the mesial. And I'm moving the camera, I'm closing the angle and opening the angle, and this is what I call step wedging. Okay, turn a little more to the left. Now I'm going to look in the mouth, position this at the distal lingual of the first molar. You can see right there, some calculus. This crown has a kind of an open margin. You can see there's the prep margin right there, and there's the margin of the crown. And it's pretty apparent from this endoscopic angle. And then the pocket's shallow, so the water's not getting to the tooth unless I have the ultrasonic in between. Now I'm bringing this around to the mesial aspect of the first molar. You can see there's a crown margin, there's the tooth, the shield, and I'm going in sideways to clean the mesial aspect of the first molar from the lingual. Okay, so what I'm going to do is I'm going to change the explorer. So I'm going to have Katrina do this as well. But I'm going to show using the angled explorer. Okay, so I've changed the explorer. Now I'm going back to the distal of the second molar, and I put it in sideways, position my instrument, look at the screen. And now I'm seeing into the distal of the second molar. The temptation is to look in the mouth and then look at the screen like this while you're bent over. But when you look in the mouth, go ahead and look in the mouth, then sit up straight. And that concavity, I can't get the ultrasonic into that concavity like I want to, because it's not going forward enough. So what I'm going to do is I'm going to change this to the curved ultrasonic. Before I start going, I want to know my position is right, and then I want to check the tuning so that the water's swelling. Now I've done this for almost 15 years. I've taught it all over the world. I've probably treated well over 1,000 cases, cleaned well over 10,000 teeth. So for me, this is easy. At the beginning, it's not so easy. It takes a lot of coordination. It takes a lot of patience. If you don't have patience for this, then you're not the right person to do this. Because not everybody is going to be super good at first. It takes a lot of practice. But then again, learning all those hand instruments and doing it blindly, that takes a lot of practice too. And you still can't see what you're doing, and you never know when you're finished. In our practice, my perio practice, we hardly ever do surgery to treat periodontal disease. What I don't recommend is doing a lot of looking, just looking. You should be looking while you're cleaning. You'll notice that my feet are on the pedals and I don't take them on and off. Go back and forth and on and off. That's too fatiguing and it's not as efficient as just keeping your feet on the pedals. And you'll notice the saliva ejector has a nice even sound. That's because of the soft stop. You'll also notice that I don't have an assistant. My assistant is the saliva ejector. So what I'm going to do is put this back and then we'll have Katrina go in and start things up. I'm going to take everything apart. The old system used to have a little handle here where you put this when you're not using it, but that's really inefficient. We just put the instruments on the tray where all your other instruments are. Okay, put the prop in. So you've got a really good view of the distal lingual aspect of the second molar. You can see in the lower right-hand side of the screen is a shield. Right in the middle to the left is a tooth. And the upper left quadrant is a gold crown. So yeah, just try to keep the ultrasonic in the visual field. And then you can see it's clean, so start moving. It's real important that patients are anesthetized. You know, I think we should be using local anesthetic for this, not topical anesthetic and not Oracix or the injectable topical anesthetic. It's just not good enough. Some patients obviously can tolerate quite a bit. Good, you're doing great. So you're kind of half feeling, not half feeling, but a little bit of feel, a lot of bit of looking. Okay, close that angle up. Good, keep coming around, move a little bit now as you're looking. Good, close that angle. Keep moving. See, this is a real shallow pocket, so that the water's not hitting the tooth. If you put the ultrasonic in there, it may help to decant the water onto the tooth. So you're always looking through water. Okay, go to the mesiolingual line angle. There you go. Push that in there a little more. Push the tip in there. You always want to have the tip of the Explorer on the tooth if you can. Because that pushes the most amount of soft tissue out of the way. Close that. Close this angle a little. Yeah, good, good. Another reason we want to use local anesthetic is because you need to push the camera to the apical extent of the pocket. You want to make sure you get it all. What we know about blind scaling and root planing is that the apical limit is 4 to 5 millimeters as far as being effective. Anything past that, you're probably not going to be as effective without looking. So there are only two ways of visually accessing roots. One, open it up, or open debridement, and two, endoscopic debridement. So for example, if you look at medicine, medicine has cameras that pretty much go everywhere. And you wouldn't have your knee cut open if you could have it scoped. And most of us know someone, including ourselves, who have had either a shoulder or a knee endoscopically treated or arthroscopically treated, as it is for a joint. This is the only dental endoscope that you can do something with. There are other scopes, but they're basically really tiny endoscopic or intraoral cameras. This system has been proven for the last 15 plus years, and it's only been more refined to the point now where we have a much better image, a much more reliable system. The more toward the anterior you get, the more you can see on both sides of the tooth, the buccal and the lingual, with the straight explorers. The further back, the more difficult it is to see on the distal aspect, so you have to use the bent explorers, or the right and the left. Now you can see every once in a while you get these air bubbles coming up, and that's ultrasonics creates cavitation, and cavitation is the creation of bubbles. So what I noticed is that magnetostrictive ultrasonics, because it's 25,000 cycles a second, doesn't create as many bubbles as piezo does. Piezo is typically 40,000 cycles per second, and you tend to get a lot more bubbles. So, close this angle, push it in, open it. Good. Keep going. So you can see she's not putting the ultrasonic down because she doesn't have to. She's just changing the explorer, holding on to the ultrasonic. Again, she's holding the explorer just like she's going to hold it to put the sheath fiber complex in. She's going to hold it the same way to unclip it. This is one thing I say a lot during the training is look in the mouth, position the instruments, look at the screen, and clean. Then move around while you're cleaning. Having done my share of periodontal surgery, there's a lot more room for this little tiny camera and the ultrasonic than there is to try to flap it open. A lot more room. Especially on the lower lingual, it's much more difficult to flap access on the lower lingual with the tongue there. I read articles about how to use ultrasonics when you're not looking, and you're supposed to develop a pattern. You're not supposed to be just real random. But when you can see what you're doing, things aren't random at all. And you can see how your movements are a lot smaller. That tip of the ultrasonic the very tip is about a 0.5 millimeter in diameter. Okay, now I'm going to go back to the distal. I've got the right, so I'm going to go to the distal. I normally go from the distal to the mesial, distal to mesial. Sometimes you can cross instrument, like I have the instrument coming in from the lingual now. The camera coming in from the buccal. Sometimes that works, sometimes it doesn't. A lot of times on the lower though, it works great. Okay, now I'm going to go to the upper right, so I'm bending this just the opposite way. Okay, open real wide, good, close. Turn to the right. Good, so I'm going to do a tactile debridement. And I normally tune things in the mouth because you're working in the mouth. Why not doing it in the mouth? You don't have to go over there and do it. You're going to get a bunch of water in here anyway. At first, probably going to be doing maybe a quadrant at a time. Our hygienists are doing full mouths typically, all the time in an 1.5 hours to 2 hours. Most hygienists, most practitioners are doing half mouths, and they're doing an 1.5 hours to 2 hours for a half a mouth. Well, if you automate your procedure and you try to be as efficient as possible, switching explorers, and you have a method, and that's the method that we teach, you should be able to do this faster. This is how ultrasonics works. It's high levels of vibration that essentially crush things off, or vibrate things off in the case of plaque. In the case of calculus, it just crushes it. We used to say, or we used to think, that pushing harder would dampen the vibrations and it wouldn't work as well, but these instruments are tuned to want to stay tuned. And so what we find is these pushing harder gives you more power, actually. Now certainly pushing harder with the tip can actually gouge the root. So that's why seeing is important. When you can't see, you have no idea what you're doing. And if you think your tactile sense is good, it may be good, but it's not that good. So what we say when you do perioscopy is you check your ego at the door. Okay, open, close. Now I'm going to switch to the left explorer. The left explorer is going to allow me to see the buccal and the mesial aspects on the upper right. Okay, turn up straight. I'm going to angle my ultrasonic so I don't have to fight with the handle. And make sure that this is all the way back there. When I'm doing it, I was just thinking, when I'm doing this, it's like I'm on a cooking show. You know, people are talking all the time. Oh, I'm chopping this, and or I did this with my aunt and my uncle. You know. This is how we do it in the homeland in Italy. You know, It's funny. Probably the most common diagnostic thing we see is caries interproximally, especially on crown margins where you can't see them on the X-ray. Every once in a while I get a referral for a fracture rule out. So we'll anesthetize the patient, put the camera in there, clean, and see if there's a fracture. And sometimes it's fractured, sometimes it's not. Let me check that margin. Yeah, that's soft, so that's caries there. So we'll let her general dentist know that she has caries on the distal of number 4. It's interesting. I think we discount the need to know about and teach ultrasonics. The technology, okay, open, close. The technology of manually tuned magnetostrictive ultrasonics is from the late 50s. It's nothing new. Okay, so I'm going to go in with the left explorer because we're going to be looking at the mesial of number 19. That's where she's got a 4 millimeter measurement. And I just want to make sure that that's clean. So put it in from the buccal, position the instruments, look at the screen, and clean. Step wedging into the interproximal. Be able to smooth out a little bit. I'm going to cross instrument. And when I see myself come around the corner here, I know I've cleaned the entire mesial. That crown margin is not the best. What I'm doing is I'm pushing harder. That's removing that enamel that's part of that ledge. So what I've done is I've smoothed off that ledge just by pushing a little harder. Okay. Initially, this training is very much like learning how to use a dental mirror. You look in the mirror and you're just going, I don't know if my brain can get this. And then the next day, you're looking in the mirror again and you're going, oh yeah, okay. So what we know about these kinds of visual learning is that your brain needs a rest. That's why in our normal training, we do the didactics before the training, watching the videos. If you play video games, it's not a bad idea. If you learn how to use chopsticks with your non-dominant hand, that's not a bad idea. Just to kind of get you prepared for this, what you're going to be doing that day. Then we do the bench training and take you to the steps of looking at a screen, then getting into using both hands, and then you go clinically to use both hands and both feet. So the typical training, the day of training is bench training. We've already got the didactics out of the way. We see a patient in the morning, and then we have lunch, then we see two patients in the afternoon, and try to get some experience with all four quadrants and all four explorers. And then the big thing is just to practice. It takes about 10 cases, I would say, to become fairly familiar with what you're doing, setting things up, knowing how to position, looking at the screen, letting the screen govern your movements, thinking about whether you're comfortable or not. Then I would say after about 20 cases, you get to a pretty comfortable level and you start being proficient. You should start seeing amazing results as well. You made it. Okay, so afterwards, don't eat or drink anything until you can feel everything, because we don't want you to bite your cheeks. A lot of times if you're all numb on the lower, you could bite your lip, you could bite your tongue. So, just wait till you get all your feeling back before you eat anything. You can probably drink something because you can feel your lips, right? Mm-hmm. Okay. Afterwards, you may have a little tenderness in your gum. You may have a little bleeding. If you're not sure about anything, call us. Mm-hmm. We're going to give you some Aleve to take later, or naproxen sodium to take later if you need to. Mm-hmm. That would be maybe about 3 or 4 o'clock. Mm-hmm. And just take it as needed. Mm-hmm. You're going to have some tenderness in your gum line when you brush and floss. Are you using a water pick? Mm-hmm. It might be a little bit tender using a water pick, but by tomorrow it's probably going to feel real normal. Mm-hmm. Okay.